Hello, welcome to NOCC's Ask the Expert series. I'm Alana Feuchter, and today we are delighted to have Dr. Ashley Haggerty joining us to discuss decision-making in frontline maintenance therapy. Dr. Haggerty is an assistant professor of gynecologic oncology at the Hospital of the University of Pennsylvania. She received a BA with honors in the history of science, history of medicine from Yale, and an MD from Wake Forest University. She completed a residency in obstetrics and gynecology and a fellowship in gynecologic oncology at the University of Pennsylvania. She currently serves as chair of Gynecology Quality Improvement and is the physician lead for the Women's Health Unit-based Leadership Council. In addition to practicing the full scope of gynecologic oncology with surgery and chemotherapy, her research focuses on cancer care delivery and quality of care. Dr. Haggerty will answer questions at the end of her presentation, so please type them in the chat box below. Keep in mind that we will not be answering any questions to your specific circumstances, only general questions that will pertain to a larger audience. Now I would like to hand it off to Dr. Haggerty. Welcome.
Thank you, Alana. I'm really delighted to be here and to talk to you guys about what's really a rapidly changing environment that makes us really excited about the treatment for newly diagnosed ovarian cancer. So as many of you know, ovarian cancer historically was treated potentially with surgery and then with chemotherapy with carboplatin and paclitaxel. And that has remained unchanged since the late 90s. And it's only been within the last decade that there's been newer drugs approved for newly diagnosed patients. This is a very rapidly changing landscape, and I wanted to take the beginning part of this before we get to the questions to talk a little bit about those specific trials, the drugs that have been used and studied, and how your doctors may help you make decisions about what might be best with your newly diagnosed cancer. We know that this is really important because unfortunately, as many of us know, the vast majority of people are diagnosed with their ovarian cancer at an advanced stage, at least stage 3 or higher. And although with a combination of chemotherapy and surgery, we may get about 3/4 of people into a first remission, up to 80% of people will recur at some point from their cancer. And in the recurrent setting, while we may be able to treat your cancer for potentially long periods of time as more of a chronic disease, we are unable to cure people at this point in the recurrent setting. There's been lots of research over the years about different treatment options in the recurrent setting, and that is still very active and ongoing. But what people have seen is also really important is recent research into newly diagnosed patients. Because if we can make a difference in the newly diagnosed patient setting to potentially delay the time for cancer to come back, or even better, prevent it from coming back altogether, that would be a huge win and a benefit. Other trials have looked at particularly chemotherapy options over the years, things like continuing monthly Taxol. But those trials really didn't show a significant benefit for patients. So I really want to focus today on the fairly dramatic paradigm shift of what happens for patients after they are newly diagnosed. You know, previously, patients would either have surgery first or maybe neoadjuvant chemotherapy first and then interval surgery. And then after they finished around 6 to 8 cycles of chemo, options included close monitoring, and some of these maintenance things had been studied, but nothing had been improved. So this first started several years ago with studies looking at Avastin or bevacizumab. That is what's called an anti-angiogenic agent, focusing on affecting how the blood supply is grown into tumors. So it was a focus away from other chemotherapy options and looking at different ways to treat how cancer cells divide, in this instance, notably how they get blood supply to divide. So there were 2 clinical trials that looked at Avastin in newly diagnosed patients, one in the US and one in Europe. And it was both of these trials that led to bevacizumab in the last couple of years obtaining FDA approval for the use of a maintenance therapy in newly diagnosed patients. I'd like to spend a little bit of time going through the specifics of those trials because that's, again, how your doctors tend to use the data from these trials to see if this is a good medication for you. So for the trial in the US and for the trial in Europe, it was several hundred patients in both trials. And in the US trial, it was actually 3 arms. So the first group got just chemotherapy and placebo. The second group got chemotherapy with bevacizumab, followed by placebo maintenance. And the third group got chemotherapy with bevacizumab maintenance. All of these trials that we'll be talking about today are done in what's called a blinded fashion, meaning the doctors treating did not necessarily know what treatment people were on. And the trial here in the US demonstrated about a 4-month improvement in what's called progression-free survival, or the amount of time that it takes until someone's cancer comes back. Unfortunately, there was no difference in what's called overall survival, which is essentially preventing the cancer from coming back at all. In many of these cancer trials that are done contemporarily, it's felt that progression-free survival, or the time to recurrence, is an acceptable sort of trial design option for what a goal of treatment is to at least start with. So it was that improvement of about 4 months, from 10 months in the group that did not have the active drug, that had placebo, to 14 months until cancer came back in the group that did have bevacizumab. There was no difference in the group that just had bevacizumab with their chemotherapy, followed by just a placebo. People have looked in that study about if there were certain subgroups of patients that benefited further besides that 4-month difference. And when you look at both the US trial and the European trial, there actually was. So there were groups that were felt to be more high risk that did have a significant benefit, including an overall survival benefit. Those groups were patients who presented with stage 4 disease, had significant high risk factors, including ascites or fluid in the abdomen, or had a surgery for a stage 3 disease where their tumor was felt to either be unresectable or the surgeons were unable to remove all of the tumors, and tumors measuring at least a centimeter were left behind. So many people, although that wasn't the original design of the trial, use those categories for who may be offered Avastin more so than other patients, although it is approved for all patients. It's important to talk about the side effects of any of these drugs when we're talking about maintenance therapy options, because many patients are treated to be on these trials, and to get a maintenance therapy, you have to have either had a partial response, meaning some of the cancer shrunk and went away, but there's still measurable cancer. Or ideally, to your initial therapy, you had a complete response, meaning all of the cancer is gone and there's nothing measurable. So it's really important to find a good balance of treatment options that provide a benefit without too much toxicity, particularly for people who have no active cancer. You don't want the drug to significantly outweigh the risks than the benefits. So for people who use bevacizumab for maintenance therapy, it tends to be a drug that's very well tolerated. The most common side effects we see are sometimes fatigue and joint muscle aches and pains. People describe it often like having a hard workout and feeling sore after. About a third of people will actually have an elevation in their blood pressure. Most of the time that's able to be managed either just with close monitoring or even starting or adding blood pressure medication. Avastin does have some rare but potentially very significant side effects. Those can be blood clots, either blood clots in the legs like DVTs, a blood clot in the lungs called a pulmonary embolus, or rarely strokes. It can lead to poor wound healing and can have a rare risk of fistulas, or when things that shouldn't be connected are connected, like the bladder to the vagina, and can have a rare risk of spontaneous bowel perforation or a hole in the bowel. We do know that there are some factors that make people more high risk for these things. So that's why bevacizumab may not always be a good option for all patients. Because there was a significant benefit in that progression-free survival, or the time to recurrence, this was approved by the FDA in the US based on this data. But research has been ongoing to see if we can, improve and find other ways that may even provide more of a benefit. And that's where the role of Parp inhibitors come in. I'd like to spend the next couple of minutes talking about Parp inhibitors as a general class of drugs. There are several different Parp inhibitors that are currently approved. And then again, talk about the couple of different trials, particularly published in even the last several months, that have really changed the landscape of how we're treating patients who are newly diagnosed. The details about these trials and who was included in the trials and how the trial was designed for how the drug was used is often how your doctors determine if you were someone that would be a good candidate, particularly for some of the combination drug trials that we'll talk about here. So Parp inhibitors are a category of drug. They are given orally, so it's a pill that you take at home. As many of you may know, bevacizumab is still an IV drug that you typically come into the chemotherapy suite to receive. The Parp inhibitors were originally studied and approved in the recurrent setting. It's also a drug that's used in several other cancer types, breast cancer, prostate cancer, and newly pancreatic cancer being one of them. Initially, the drug was studied in women who have a BRCA mutation because the way the Parp inhibitor works takes advantage of abnormalities in how cells repair themselves. So when people have a BRCA mutation, or any mutation is in what's called the homologous recombination pathway, which is what helps cells fix DNA repair breaks and prevent cells from dying. When you use a drug like a Parp inhibitor, it blocks the repair mechanisms that were inherent in the cells. And instead, the cells can't repair the DNA breaks, and those cells go ahead and die. People who have a BRCA mutation actually lack the Parp enzyme to help repair these double-stranded breaks. So this is where the science came into play for why it was originally studied in patients who first have a BRCA mutation or have any mutation that's in that homologous recombination pathway. There's newer data that shows that it's in addition to a BRCA mutation that's inherited in your genetics, there are also mutations called somatic mutations in the tumor itself. And then there are also this category called the homologous recombination deficiency, or HRD, that can be tested. There's currently one FDA-approved companion test for it. And it essentially gives a score of if it appears that the tumor cells behave in this homologous recombination deficient pathway. The first drug that was used for Parp inhibitors for frontline maintenance therapy was olaparib, and it was used in a study called SOLO-1. And that study included women who had a BRCA mutation in either their genetics or their germline, or their tumor or a somatic mutation. And it was for BRCA mutations only. It was for patients who had an advanced stage, so you had to be either stage 3 or 4. You had to have either high-grade serous or endometrioid histology in terms of microscopically what type of tumor you had. And in that trial, patients were assigned to either the Parp group or a placebo group. It's an oral medication that starts several weeks after your chemotherapy finished. And in that study, patients went on to receive 2 years of treatment. You had to have at least a partial response or a complete response to your initial chemotherapy. And if you had only had a partial response and you still had visible tumor, you were allowed to continue your Parp inhibitor past the 2 years of treatment. Very importantly, this trial demonstrated a 70% decrease in the risk of cancer coming back, or that progression-free survival. The study statistics showed that at 3 years, 60% of people were still free of disease, compared to only 27% of the people who had received the placebo. And the median time to your cancer coming back was almost 52 months if you had received the PARP inhibitor, compared to about 15 months if you received placebo. This resulted in FDA approval for olaparib as frontline maintenance therapy, but only for women who had a BRCA mutation. Ongoing trials at the same time started to look at some of the other different PARP inhibitors, as well as other patient populations. So the Prima Trial was a similar trial design. It used a different PARP inhibitor called niraparib, but it allowed all patients to receive the study drug versus placebo. Importantly, though, you again still had to be a stage 3 or 4, but at surgery, you had to have been a stage 3 surgery that still at least had a microscopic amount of tumor left behind. So if in surgery a patient had all visible tumor removed, they wouldn't have been allowed to enroll in this trial. And these are the notable details of how decisions are made for potentially benefit of patients. If you had originally been able to be enrolled in the trial, we would feel like the trial results are very applicable for your care. In the Prima trial, again, it allowed either high-grade serous or endometrioid types of tumor. Again, you had to have either a partial or a complete response to your chemo. And they reported the results based on if you had BRCA mutations, either in your genetics or in your tumor, and what that HRD score was if you were positive or negative. You had to start the PARP inhibitor within 12 weeks of chemo. And in this study, patients continued on the drug for 3 years instead of 2. Again, importantly, this really demonstrated a significant improvement in the time it took for a patient's cancer to come back. But notably in this trial, that improvement was there for all patients, regardless of if you had a BRCA mutation or HRD mutation. And that's why recently the FDA approved niraparib for all patients for frontline maintenance. It's important to note, however, that the degree of benefit was much more for people who had a BRCA mutation and for people who had an HRD mutation. So for all patients, if you took the PARP inhibitor, your improvement in that progression-free survival was almost 14 months compared to 8 months. But if you were HRD positive, your improvement was 22 months compared to 10 months. And if you were BRCA positive, it was again over about 22 months compared to about 10 months. The importance of this is because there are some patients that do have side effects from the PARP inhibitors. So overall, the PARP inhibitors, again, tend to be very well tolerated by patients, but particularly in the 2 trials that we've already discussed, there were side effects that were reported. And actually in those 2 trials, over 90% of people had at least some side effect that was reported. It might have been something like fatigue. We know PARP inhibitors potentially decrease your blood counts, causing things like anemia. There can be nausea or vomiting associated with the PARP inhibitor because it's an oral drug. That's typically managed for most patients by taking some nausea medicine, particularly about 30 minutes before you take the PARP inhibitor. Again, there can be things like joint pain. There can be other side effects like affecting people's kidney function lab work that doesn't appear to be permanent, but it can be brief. And so it is really important to think about these side effects for if you would first be eligible, because things like your hemoglobin and your platelets have to have recovered if you had significant side effects with your chemotherapy. And if you're having a lot of side effects and toxicities with the PARP inhibitor, your doctors may take into consideration some of the things like if you have a BRCA or HRD positive result for the degree of benefit we think you might have versus a lower degree of benefit to decide if it's a good drug for you. But we were really excited to see the FDA approval for this drug for all patients. There have been other trials that were also recently reported and recently resulted in FDA approval that combined the bevacizumab with the PARP inhibitor. So this trial was called the Paula trial. And again, it reported the results based on if you were BRCA or HRD positive. It had a significant improvement for patients who were BRCA or HRD positive. And that was what just in the last several weeks, the FDA approved the combination of bevacizumab and olaparib. It's important to note that in this trial design, the bevacizumab was started with the chemotherapy. So that's a decision that needs to be made when you originally start your treatment to then have the bevacizumab continue after the carboplatin and the Taxol is complete, and then adding the Parp inhibitor to that. A fourth trial that has also been recently discussed is called the Velia trial that used another Parp inhibitor called veliparib. And this trial combined the Parp inhibitor with the chemotherapy to begin with, and then followed with just Parp inhibitor alone as a maintenance treatment. Again, in a similar fashion, it was patients who were stage 3 or 4, but it also included patients who had chemotherapy first and not surgery, which meant that all patients could be enrolled and started on a Parp inhibitor, unlike the trial with niraparib, in which you could only start the Parp inhibitor if you still had residual disease that could be seen after your surgery. That was not the case to start therapy in this trial. This was also a 3-arm trial. So some patients had chemotherapy with placebo, followed by placebo maintenance. Some patients had chemotherapy with a Parp inhibitor, followed by placebo maintenance. And then some patients had chemotherapy with the Parp inhibitor, followed by Parp maintenance. The study results demonstrated that just adding the Parp inhibitor to the beginning of chemotherapy and not continuing the Parp inhibitor made no difference. But again, demonstrated a significant benefit for when the Parp inhibitor was continued as maintenance therapy. And this was a broader patient population that was allowed to receive the chemotherapy. And importantly, this was a study that showed that while there were higher side effects when we combined the Parp inhibitor with the chemotherapy, those side effects weren't too extreme and people were able to stay on both medications. We did see higher rates of affecting people's blood counts, which is not unexpected since we know chemotherapy can lower your blood counts, and as we discussed, the Parp inhibitors can lower your blood count. But the combination of those were well tolerated by people. So there's also been ongoing trials that we're really excited to hear the results about that are combining Parp inhibitors, notably rucaparib, which is the other Parp inhibitor that is approved in the recurrent setting. And in this trial, the Athena trial, they are combining the Parp inhibitor with an immunotherapy agent as maintenance therapy. We are anxiously awaiting those results. And I think this trial demonstrates that people are continually trying to move the mark and really improve the outcomes that we can see with people's upfront cancer treatments. I think it's important to note the other types of clinical trials that are ongoing that are also currently enrolling are other trials that use the combination of immunotherapy with a Parp inhibitor. And there's another trial called the GOG 3025. It's run by our cooperative research group, and that also adds the bevacizumab to this. So this is really an exciting time as we're taking all of these different drug combinations, putting them together in different combinations to see if we can continue to improve outcomes for patients. And I think the important thing to take away from these stories of these successful clinical trials that we've talked about is that I think that there's an unfortunate misinterpretation of clinical trials as being only reserved for people who have used up all of their typical treatment options and are really end stage in their treatment. And we can see with these results that that is definitely not the case. and that clinical trials are really how we advance the cancer care that we give to patients. And so I think this is a great opportunity to encourage clinical trial participation because we can see with these results that people get an immediate benefit potentially from clinical trial enrollment. I hope that answered some of your questions, and I'm happy to take some more questions right now.
Thank you so much, Dr. Haggerty. That was a lot of information in a short amount of time, and I think I'm going to wait for some questions, but I was jotting down some that I think I've heard other people ask before. So are there any, or how long can you stay on some of these maintenance drugs?
Yeah, it's a great question. So typically we keep people on a maintenance drug until cancer returns or people have severe side effects. In those clinical trials, while we said most people had some mild side effects, the rate of people having a severe side effect was significantly lower, maybe about a third. So sometimes treatment needs to be discontinued if you can't manage those side effects. Otherwise, the olaparib trial continued a Parp inhibitor for 2 years. The niraparib trial continued it for 3 years. And the trials using bevacizumab typically continued for around the same amount of time, although there are certainly patients that continue on for longer periods. There's a slight risk with Parp inhibitors of a rare type of leukemia. So it's less than about 1%, but that's one of the reasons that it may be reasonable since it clearly shows a significant benefit with several years of use, but that use does not appear to need to be continued past those first 2 or 3 years.
Okay, as we've been chatting, we've gotten lots more questions. So when is the anticipated end date for the Athena trial?
Yeah, that's a great question. I don't know when the study results will be reported. Patients are ongoing with their treatment, and it tends to take sometimes a year or 2, if not longer, to have results to be published or at least presented at one of our large society annual meetings. I would imagine that it will still be about a year or 2 before we get those results.
Okay. With the COVID pandemic, how have clinical trials for ovarian cancer been impacted?
It's a great question.
The trial.
Yeah. So some of that has depended on location of where you are getting your treatment. There are some hospitals that had to shut down all clinical trials because of such a high burden of disease. There are some that allowed certain trials to continue, particularly trials that were felt to have a really significant treatment effect to them. It's been interesting because the trials that use, for instance, a Parp inhibitor have been more successful in continuing because it's an oral medication that you take from home. You don't need to come into the infusion suite. So many trials have been ongoing, and at least, here in Philadelphia, we are now back open to the vast majority of clinical trials, including things that are, survey trials or not treatment trials.
This is another good question. The question is, are there any trials in the works, or I guess this would be for maintenance therapies for germ cell ovarian cancers? And another question I had is for all other cancers besides the endometrioid or the high grade, what kind of maintenance therapies do you have for them?
It's a great question. So, and that's why, I wanted to spend some time talking about the specifics of who was included in the trial, because that's often how your physicians decide if we think the results of that trial would apply to you. And so most of these trials, as we talked about, included only high-grade serous or endometrioid type, although if patients are found to have a BRCA or HRD positive tumor, you could extrapolate that you may have similar benefit. One of the trials did have several patients that had a clear cell. However, other types like germ cell are not felt to necessarily have the same abnormalities in the way the cancer cells divide to be targeted by things like Parp inhibitors. I think as we are making these advances in our treatment for cancers, we're realizing that the type of cancer and treating sort of all ovarian cancers in a blanket treatment strategy may actually not be the best strategy. And instead looking at these things like the molecular profiling that can be done of your tumor to see what kind of targeted mutations you might have in your tumor. And then the trials that are ongoing are often lumping tumors that have those types of mutations, but may come from different organ systems. So tumors that are urologic tumors, but have a similar mutation are being studied for a particular type of drug and not just for ovarian cancer alone.
So it's very important to have your tumor tested for all of these various mutations.
It is. We've seen that although sometimes there are not informative mutations that we can take action on, sometimes there are. And so that is often very helpful information for your cancer doctors to use for potential treatment strategies. Many of these clinical trials, often if they are using more of that targeted therapy, will check and the ability to enroll depends on your tumor having that abnormality, for instance.
I'm not sure I'm going to pronounce this right, but a question is, are you only discussing trials using Parp? And if not, what do you know about the mirvetuximab combination?
Yeah. So those are also ongoing trials that are looking at other immunotherapy agents. So we know that ovarian cancer, and when the ovarian cancer that I'm referring to is the epithelial ovarian cancer, so tumors like high-grade serous endometrioid. We know that those tumors can be very immunogenic, meaning they can respond and have a higher response to various therapies that sort of affect the immune system. And there are many ongoing trials to use that as a treatment strategy, differing than our historic usage of just carboplatin and Taxol that just affected all rapidly dividing cells. The mirvetuximab and the other trials that I discussed, the Athena trial, the other GOG trial that's using durvalumab, these are all ongoing trials that are looking at immunotherapy for patients. There are multiple ongoing trials in the recurrent setting that's also looking at immunotherapy, as well as other strategies that take advantage of the body's immune system to see if we can turn on certain cell types in the immune system to make them specifically attack cancer cells.
Okay, that was very informative. Here's a question. Is there any liquid form of a Parp inhibitor?
There isn't. They are all oral pills, and the different types of Parp inhibitors have different dosing. And so that might be one of the things that comes into play in terms of, choice of Parp inhibitor. The rucaparib Parp inhibitor is 2 pills. Olaparib is 2 pills. The niraparib is 3 pills, but the niraparib is only once a day. So they are oral pill medications that you do need to take as a whole pill. So it's really important. They are approved in the recurrent setting, but in that setting, people have to not have such significant side effects from their disease like a bowel obstruction, so that they have to be able to swallow and absorb oral medication.
Okay. Is there an easy way for people to find out about some of the trials that are going on in ovarian cancer and, of course, at Penn as well?
Absolutely. So clinicaltrials.gov is the national website that you can search. You can even search with specifics related to ovarian cancer to show what active ongoing clinical trials are available. All clinical trials have to be registered on clinicaltrials.gov. Now, those may show trials that have already completed enrolling patients, but that's a great place to start. You can always call your local cancer center and ask what clinical trials they may have open for you. Clinical trials are constantly opening and closing. So it's always a great idea to really touch base on a frequent basis, particularly for patients in the recurrent setting, we always tell patients before you start a new treatment to check to see if there is a clinical trial that you would qualify for. In the recurrent setting in particular, sometimes there are limits to how many types of chemotherapy you have received. So it's really important to get that information before you decide on a standard chemotherapy option that may make a clinical trial not available for you anymore.
That makes sense. Okay, I think we have hit on all of our questions and we have passed our time. So I definitely want to thank you for the volume of information that you provided. There was a lot of good questions, so I know that it definitely resonated with survivors who are out there watching. So thank you.
Of course, happy to help.
Those who also asked the questions, because we like to have feedback from you so that we know what your questions are. If those of you who are watching have ideas for future topics that you would like to see addressed, please include those in the chat box below too. And I hope that we will see all of you back for our next Facebook Live, which is July 16th. We are going to do an art form called Zentangle that can be used for stress relief. And then we are going to do a session for caregivers on July 30th. So I hope everyone will join us again. And again, I thank you so much for your time today, Dr. Haggerty. It is much appreciated.
Great. Thank you all.